Welcome and thank you for allowing us to come here today to speak to you about stroke. My name is Lindsay Butler. I'm the Interim Education Coordinator for the Southwestern Ontario Stroke Network. We as the Southwestern Ontario Stroke Network identified for this year that education for grade risk paramedics is a priority. So that's why we're here today. Today's education is going to mirror one similar done in London in 2011. However, we've geared it towards grade roofs by sending out a survey monkey in about April to identify practice issues and learning needs that paramedics here are experiencing. We partnered with Bruce County EMS in terms of having a live in-person presentation and partnered with the Southwestern Ontario Regional Base Hospital Program to be able to do it via webinar, which is the go-to webinar, which Stephanie is going to speak to.
Perfect. So most people who join our webinars have done so in the past, so hopefully this isn't new to anyone. But if it is new to you, and actually the fact that we're using video integrated into our webinars today might be new to some of you. So one of the tools you can use in your view right now is to adjust the size of your video versus the size of the PowerPoint. So for those of you who are watching off-site, you should be able to see a video portion and a PowerPoint portion. You can see two boxes, two panes. If you want to change the size of either of those, you'll be able to see two parallel lines between the two panes, and you can adjust the size of each by moving those parallel lines. So it looks like an equal sign where that yellow arrow is pointing to right now. So feel free to go ahead and change those sizes. Do whatever works for you. In terms of the way that the webinar is going to work, is we'll have the presenters, as Lindsay was saying, and we'll also be able to take questions throughout the presentation via the chat box. So if you have any questions throughout the presentation, go ahead and type them into the chat box, and we can either answer them for you in the background or we can present them to the presenters so that they can answer the questions so that the entire group can benefit from the answer. Otherwise, we can open up the microphones at the end of the presentation to take any live questions if you do have any. If you do have a live question at the end of the presentation, keep in mind that you will need a microphone attached to whatever device you're using. If it's a laptop or smartphone device, you'll need a microphone attached. If anyone is watching virtually and you are in your partners or in your station, there's someone else watching with you, just let us know and we'll get both down for attendance. Otherwise, I think that's all I have, so I will hand it back to you, Lindsay.
So the outline for today's presentation, the introduction is into the stroke update is going to be done by Joan Lestenberger. She's the Grey Roof's District Stroke Coordinator and Manager of Rehabilitation and Restorative Care. We'll then move on to the stroke update with case studies by Dr. Evie, who's the Medical Director for Grey Roof's Base Hospital and ER physician, as well as Dr. Chan, who is our stroke neurologist at LHSC. For those in person, all of these presentations can be found in your handout packages. In terms of an evaluation, we'll be doing a question and answer period following Dr. Evie and Dr. Chan's presentation, and then followed by the evaluation. For those in person, you can find that evaluation on a blue piece of paper. And for those joining via webinar, Stephanie will be sending that out, the link via email. We greatly appreciate your feedback on today's session, how it went, what you thought, and as well as some future learning needs related to stroke care. So today's session would not have been possible without the financial support of the Southwestern Ontario Stroke Network, the technical support of the Southwestern Ontario Regional Base Hospital Program, the coordination of the live in-person event by Ray Lux here in Bruce, and with special thanks to Wendy as well, and then for our planning committee who are here with us today. And then also, most importantly, is the respondents from the Survey Monkey in April that helped build our presentation to deliver to you today. And then last but certainly not least, our presenters, Joan, Dr. Evie, and then Dr. Chan. Before we move on to the presentations, as the Education Coordinator for the Stroke Network, I just wanted to bring your attention to an upcoming education event. This is a stroke rounds presentation that's going to be happening on June 4th, titled Evaluation and Implementation of the Revised Paramedic Prompt Card for Acute Stroke Protocol. You could be viewing it via OTN or live or archived webcast. We sent the information to your leaders, so you should be able to access that information. And then lastly, I just wanted to let you know, if you do need to reach us, this is our contact information. And also point out to you the website, swostroke.ca. This is a website designed for healthcare professionals invested in education for stroke care. And we have a regularly updated education calendar there. And then your more local representative is Joan, who's going to be leading our presentation today. Side by side. Okay, great. So thanks, everybody. I know on a beautiful day it's sometimes hard to sit and listen, so really appreciate your time. As Lindsay said, we're always anxious to try and partner, and we really want to talk a lot about the partnership that we have and hope to continue to have and work on with EMS. We do play a really critical role in stroke care, and we want to make sure that that we have good team. Yes. Oh, sorry. Technology isn't my thing. So just a few quick facts. So the impact of stroke care in Canada, there's about 50,000 strokes per year. There are 300,000 living with strokes. About every 10 minutes somebody has a stroke. And after you've had a stroke, you have a 20% chance of having another. And for every symptomatic stroke, there are 9 silent strokes resulting in cognitive impairment. And there's a price tag of about $3.6 billion annually. So just a few other facts. So it is the third leading cause of death in Canada and the first leading cause of adult disability. 22% of residents living in long-term care over the age of 65 have a diagnosis of stroke. And there's a high rate of caregiver burden, and more women than men die from stroke. After the age of 55, the risk of stroke doubles every 10 years, and the stroke survivor has a 20% chance of having another stroke in 2 years, and more than 1/3 of stroke patients do not contact EMS for their transportation to hospital. They drive themselves. So this is just a really quick overview. So hemorrhagic stroke, very basically where it's blood leaking into the brain that occurs about 20% of the time, and then ischemic clot is about 80% of the time. So for Grey Bruce, I'm sorry that this is so tiny to read. There are about 330 to 350 strokes in all of Grey Bruce per year, and that's been consistent over the last about 5 years. There are 11 hospitals, as you all know, in Grey Bruce, all delivering stroke care at different varying degrees. There is a stroke card that is done by the Ontario Stroke Network, and we're in the 3rd year of the stroke report card. It includes 20 indicators on varying aspects of stroke care across the continuum. And I didn't want to get into a lot of details, but I did want to let you know that with this stroke report card, there have been varying results across the province, and a lot of it hasn't been real good. So it has, the benefit is that it has allowed us to capture the data to know where the improvements need to be made. And that's exactly what is happening. Because of the variety of resources in different hospitals,
Some of the literature points to the fact that in order to have the best outcomes and to improve mortality for patients, there needs to be a critical mass of 165 stroke patients per year. So, and as I said, we have about 350 strokes spread across all hospitals in Grey Bruce per year. So the critical mass is important when we're talking about consistent and better stroke care in hospital. There is part of the movement forward is health system funding reform and quality-based procedures, and I won't get into a lot of detail about that, but it has, hospitals are going to be funded differently based on quality-based procedures and best practices. So there is a spotlight on stroke because it is one of the quality QBPs, and so changes are starting to happen. I'll talk about that a little bit later. And there is also currently in progress a LIN-funded project looking at regionalizing stroke care across the Southwest LIN. So right now there are 2 district stroke centers, one in Owen Sound, one in Stratford, and the regional center, which is in London at LHSC. And those are the ones who have had the organized, that's not a great way to put it, but it is the areas that have been funded as district stroke centers. Anyway, the regionalization project is looking at all hospitals in the Southwest LIN and trying to determine what kind of care they provide now and in the future what that might look like if we were to regionalize care into centers of excellence and provide a different opportunity for patients. So I talked a little bit about the stroke audit. One of the indicators on the audit is the percentage of patients that arrive to the emerge department within 3.5 hours of symptom onset. And the results from that audit for the Southwest LIN, about 46.5% arrive within the 3.5-hour window. In Bruce County, it's 69%. In Grey County, it's just a little over 22%. But those are the ones that arrive within the window. The numbers are still small. We still know that there are more patients that are possibly having symptoms within the 3.5-hour window, but they're not actually getting to the hospital. So again, I talked about the Owen Sound site being the district stroke center, which means that they're funded for stroke care and for the resources that are required to provide best practice care. And currently, because we're working really hard to make sure that we're meeting the quality-based procedure standards, we are working on a telestroke, becoming a telestroke site, which means that when the patient comes into the emerge department, if the physician wants to contact a stroke neurologist for a consult into whether the patient should be having TPA or is available to be having TPA, they can do that through OTN. So we're just in the early stages of that. We're also working on a code stroke within the emerge department, and much like a code blue comes in or is called, a team of professionals is called to a code stroke in that situation as well, because we know that time is of the essence when it comes to stroke care. And we're also working on an acute stroke unit with cluster patients currently that the evidence proves that patients who are seen by professionals on a regular basis or healthcare providers who capture stroke patients on a regular basis improves outcomes for patients. We know about the warning signs, this huge sign here. I won't get into much about that. but really want to talk about the fact that time is really essential. Canadians need to understand that the clock starts ticking at the first sign of stroke, and every second of delay leads to more brain cell death and a greater risk of death or disability. That's a quote by Dr. Michael Hill in Calgary. The public awareness part of stroke care is really critical as well. So we are, we always emphasize that any chance we can.
An attendee in listen-only mode.
There are best practice recommendations for management of acute stroke care, and I'm not sure if you have had the chance to look at them or not, but they are available on the Stroke Best Practice website, and they go through different stages of care, particularly in EMS. And they're part of your handouts there as well. The highlights from that update include the strong emphasis on educating the public to call 911 or EMS, and the on-site management and assessment and transport, etc. And to clarify that the critical role that EMS service and personnel play in all aspects of the stroke care, including the communication with the physicians once you get to the hospital. And again, the need for essential coordination once the patient actually arrives to the hospital in the form of stroke. So the continuum of care for stroke care is big. We've talked about from public awareness to stroke prevention, which is always the best case scenario, through the hyperacute phase, acute rehab and community re-engagement, and pre-hospital or ED phase starts with symptom onset up until 3.5 hours. The window of opportunity for the patient to receive TPA, the clot-busting drug, is actually 4.5 hours. But when we talk about it in terms of getting to hospital, it needs to be within 3.5 hours, because by the time the patient gets to the emerge, we need about an hour to do, well, hopefully less than that, because less time is better. We have to give them some time to get the CT scan done, lab work, et cetera, et cetera. So 3.5 hours. And of course, you guys are critical to all of this work. It is a medical emergency, which you know, and optimizing the care that you guys provide in the field really does improve patient outcomes. Your assessment and the management that you provide patients in those very early stages is really, really critical in order for the patient to be able to have the opportunity for potential reperfusion in the form of TPA. It's very time sensitive. So I know sometimes when you're in the field, you hear from patients or family members that, you know, I don't want to come in the ambulance to the district stroke center. I want you to take me to my local hospital, which may be 5 minutes away or 10 minutes away. But we really, and that's difficult when you're in that situation and they're saying you're not getting an ambulance once you take me to my local hospital. So just want to really emphasize that, you know, just like cancer care isn't provided at every hospital, stroke care is neither, and that's an opportunity to talk to patients and to educate them and their families that, yes, there is a hospital close by, but it doesn't provide the care that you require. I don't know why I'm struggling with this. Thank you. So again, I'm really emphasizing the time frame that is essential. So every minute of delay in treatment for the stroke, the typical person loses almost 2 million brain cells. So for each hour of treatment that it does not occur, the brain loses as many neurons as 3 years of normal aging. So time is really of the essence. Sorry, thank you. Did you? Yeah. So this is just another slide to show about the amount of brain loss. When you, I thought you might want to know at the far end, when a patient does come in for TPA, you can see that the difference in revascularization once the clot is busted. So again, talking about time to treatment and the importance of getting patients to the source of TPA quickly. It's very time sensitive. You'll see in the green, it's a little bit hard to read there, but in the green, the benefit to the patient is heightened the closer that you are to the time of onset. So 0 on the bottom there, it's minutes, 0 to 90 minutes, 90 to 180 minutes. The benefits are higher, obviously, and closer to the time of onset. And the risk, and the reason that we can only give TPA for up to 4.5 hours is because the risk to patients increases after that point. So, there we go. So the prompt card, you're very familiar with this. Just wanted to point out that we had put some reminders on the back of the prompt card that hopefully you'll find helpful in the field. So what we talked about is bringing a family member who witnessed the event and knows the patient's history. Again, it's a time frame that we need to be clear about. And if you can't bring a family member, if you could ask them to wait by the phone, get the phone number so that the nurse doc can call them. If you do know, remember to record the last seen normal time. It really is essential in the care that needs to be provided per way. And if possible, a 20-gauge IV in the AC, but anything you can get is better than nothing. And when in the emergency department, if you could connect with the physicians to answer any kind of questions, that is also very helpful. You could do a 12-lead grade. And medications, are they on the nurse? Which one are they on? And you can document that as well. And remember that seconds count, time is brain. I don't know if you have seen this. I don't know if you've seen this one. I know sometimes going through all of the stroke signs and symptoms, I'm not sure if you use another form. The standard is to have a standard form of determining symptoms. But if you are you familiar with this? Have you seen this at all? It is. It's something that's been being talked about more and more. It is American. But there are some people talking about it in Canada. Anyway, the benefit is that it's easy to remember. Fast is what you have to remember. So face, does the face look uneven? Ask the patient to smile. Does the arm drift down? Ask them to raise both arms to assess that. Speech, does there something sound strange? Ask them to repeat a phrase, and then again time that you want to do the assessment really quickly and get them on their way. So again, these are just the best practice recommendations, and I'm not sure time-wise. Or maybe just one really quick. Try not to mess that up. Okay, so just really quickly, we talked about this, the what is the pre-hospital emergency phase. The EMS Communication Center, and I'm sure this happens for you, but after dispatching the ambulance, EMS communications personnel should provide any key pre-arrival instructions. Again, about the communications piece, and they're in your handout, so I won't read them. The importance of recognizing and mobilizing and rapidly doing that rapidly to safely transport these patients is great. And remembering that a stroke can happen at any age. The information that you should obtain from your patient or family members, and I'm sure you probably do this, presenting symptoms, time of onset, or last time known well, sequence of events, any comorbid conditions, any advanced directives that they sorry, that's where you can slide. I apologize for that. And that talks about the FAST assessment. The medical stability is always a question, so of course that's the priority. So we want to make sure we advance acute stroke care, ED performance, which is recommended being 60 minutes or less from arrival to hospital or time. The CTAS level is also important. This talks about the hospital phase and the importance of coordinated care in the form of a code stroke. And again, the handover to the emerge physician is really critical. And that's just some things that will happen that you will be asked once you're in hospital, which we've already talked about. But I really just want to emphasize that you really are a key player in the patient's unfortunate event. And what you do really matters in the whole continuum of care. I know lots, it's hard sometimes when you drop patients, you never know what happens to them. Again, part of my role is rehabilitation, so I see lots of patients who have had really great outcomes because you acted quickly and they have gone on to a very full life. So really, really want to thank you and emphasize that it is you do have the ability to improve outcomes and reduce morbidity and long-term disability for patients. So I've got questions, a question mark here, but we're going to hold them because we'll do that after Dr. Edie and Dr. Chan.
Thanks everybody for coming. I'm going to drive the people who are recording this crazy because I tend to jump around quite a bit when I speak. So almost everybody here knows me. What Dr. Chan and I were going to do was present 5 cases that basically illustrate the points that Joan was making and the points that we want to make about the stroke card and things. The first one is going to take a little bit more time because I'm going to do some talking and reinforce some of what Joan says and sort of try and see if we can get the perspective and the context for EMS and why your role is so important in this. Because stroke is as you probably gathered from Joan's presentation, it's actually a huge issue. It's a huge social cost. It's a huge issue for families. It's a huge issue. The health system spends an enormous amount of money looking after people who have had strokes. And a lot of these people, Joan's number was 22%, end up in nursing homes. And that care is not necessarily, I mean, you go into nursing homes every day if you're working, and the care there is not the same as being at home. And it has huge impacts on families and everything else. We keep making these sort of analogies with heart care and MIs, and in some ways it's close, but there's a number of really significant differences because, essentially you've got stroke presents with many different types of symptoms. Okay, so it's not like a heart attack, it's generally chest pain, shortness of breath. Stroke, many, many different symptoms. And so that makes it more difficult to sort out what's involved. The decision often for stroke, there's also a lot of stroke mimics, just like heart pain or chest pain. There's lots of, the esophagus pain can be, but stroke is a little bit more difficult to sort out. And as Joan says, there's different types of stroke. There's hemorrhagic stroke, there's the thrombolytic strokes, and the difficulty that we have as the sort of the first professional providers that get on the scene is how do we sort out which of these people that there's a treatment available. And the treatment that is available for the thrombotic strokes is TPA. And again, if we can get the TPA, if we can decide which of these people are going to benefit from possible TPA and give them that within a very short time period, it is possible in the very best case scenario to reverse the effects of the stroke, prevent more damage from happening, and it gives people a much better life. However, it's difficult because unlike chest pain where you just basically do an ECG and you decide, yeah, okay, this person now with some history and the ECG, which can be done in seconds, and all of you can do now, you know which people are going to benefit from this. Also, the time limit for heart attacks or myocardial infarction is about 12 hours. We'll give TPA or TNK up to about 12 hours after the symptoms start. And again, the window, the time window for stroke is so much smaller to actually give the treatment for. And there's also so many different contraindications or things that would take a person out of a possible treatment thing. And to really complicate things further, you require specialized testing, which isn't available everywhere, to make that determination. So what then is the role for EMS? Okay. EMS's role is to try and identify the people who might be candidates for treatment, get them to a place where they can do the diagnostic testing, which is essentially a district stroke center now. Okay? They need a CT scan because that's the only way people know whether they've had a bleed, which would mean that they don't get TPA, or they have had a thrombus or a plug, essentially. And those people potentially are treatable with TPA, and there's no other way of doing it. So we need to get people there. And the other thing is that as the ECG takes 2-3 minutes, maybe 5 minutes, the worst case scenario to make the decision from the time they hit the door, these people also need a series of lab tests, and it takes time to, even once they've gotten there, to make the decision to go ahead with TPA. So that's really our role. The vast majority of strokes, and in some ways the frustrating part for paramedic services are that you're going to be transporting a lot of people that they're going to say when they get there, sorry, can't do it. It's always frustrating when you've done your best and you've actually done, you're trying to do the right thing for people, and it turns out that, well, unfortunately, they aren't candidates in the end. Okay, so that's kind of what I see our role in this is. I mean, the role, obviously, as Joan explained, I mean, just the person has to recognize that they have a stroke or recognize stroke symptoms, and this is in the community, and that's really the first stage. EMS, getting the person who might possibly benefit from TPA to a place where they can get it is our role. Emergency department, another role, and then it goes on to acute care, rehab care, and on and on. And so this is really a very small part of it, but it's a really important part. So that we want to make sure that we can do the best we can for people. So what Richard and I were going to do is sort of present a couple of cases that hopefully will illustrate some of the important points. And so it's going to be a little bit difficult because I think in the handouts these are here, and I don't really want to read a lot of stuff. But basically, case one, I'm just going to hit the highlights. I may not read everything out because it's kind of a waste of time. And then I just want you to think about this case as we go on to talk about it. So basically, private residence, unconscious male, okay? You've now got somebody who the co-worker had actually come to this person. So this person's living by themselves. Co-worker comes over to drive him to work, and he doesn't answer the door, goes in, finds the person motionless on the kitchen floor, still in his pajamas, calls 911, calls you, okay? Brief period of right-sided weakness a week ago, lasted less than an hour, we just ignored it. So with this person, at this point, would you think that this person might have had a stroke? It's unconscious, lying motionless.
Not necessarily.
Not necessarily, no. There's lots of things that could have happened to this guy, for sure. Okay? So, what I wanted to do, just briefly, was review, as Joan had done with the FAST criteria. I mean, really, if you think about the stroke card, and this is really what I'm going to be reviewing in this case, there's 3 physical findings that you have to decide are there or not there to initiate bypass. Right? Pretty clear about this. And I think Joan had gone through this. I mean, unilateral arm weakness and drift, slurred speech, or unilateral facial droop. Okay? Does everybody's pretty calm with that? Why is unilateral an important thing here? Does anybody know? It's in 2 of the criteria. Exactly. And why is that important? Yeah, because unilateral, the way that the circulation to the brain is, there's basically 4 arteries. I'll keep it simple. Richard will give us all of the recent detail about this, but I'll keep it simple. There's basically 4 arteries that feed the brain. There's carotid artery and a vertebral artery on each side. So if this person is going to maybe get TPA, you know, as we know, one side of the brain controls the other side of the body. So right side of the brain, left side of the body, left side of the brain, right side of the body. Okay? So if you've got symptoms on both sides suddenly, this is something that's affecting the whole brain, which would mean that there would be at least 2 arteries blocked. It doesn't really happen. Okay? So unilateral is there because those are the ones that it's usually just one artery that's involved, and so you'll have one artery will get plugged up, and then you'll get symptoms from that, the distribution of that artery. So that's why unilateral is important. So if somebody says, I've got weakness in both legs, probably not a stroke. Okay? Does that kind of make sense? Okay. So that's the first step. So now my question then is, does this particular patient that you found unconscious on the floor have symptoms that might be a stroke? Anybody?
No.
No. Exactly. No. Okay. So there's another piece on the health card which is really important, and that's the time piece. And I think this is the part where there's a lot of confusion, and certainly people that I see frequently in the emergency department who've come on bypass, this is always a big issue. Okay? And so on the card it says last seen in the usual state of health. So what does this actually mean? Everybody?
Normally confused, and like, oh, they're confused. So that the aspect usually are all the time.
Yeah.
Whether it's GCS 15 or 7 confused all the time.
Yeah, exactly. So if someone has right arm weakness all the time, that's their usual state of health. Okay? The important thing, though, is that it's the last seen time, and this is where people get really confused. Okay? And so why is the last seen time important?
It figures into the 3.5 window.
Exactly. Exactly. And the problem is that if someone wakes up in the morning at 8 o'clock and isn't moving their right side, they were last seen when they went to bed at maybe 10 o'clock at night. The problem is we have no way of knowing whether this happened at 10:05, 2, or 5 to 8. Okay? Now, if it was 2 in the morning and it's now 8:30, would that person fit for bypass? No. Okay? If it was 5 to 8, yes. Okay? So the last seen time is really, really important. And it's really important because that's when the clock starts ticking. It's not when you pick them up. That's when, for the decision even in the emergency department, and we often will get this story where you will have brought somebody, best information that we have available is, we were sitting down having breakfast and it's, suddenly these symptoms developed and we're thinking it's 8 o'clock, but in fact it was actually 7:30. Now, it may not be important if you get it acutely, but if the person then stayed at home for another hour and a half thinking about it, that extra half hour may be enough to put them out of the window. And the reason that we use this window and why this window is important is it's not so much, well, there's two reasons. One is that the treatment is less effective the longer it is. Between the time that the artery gets plugged up and it's opened up. But it's also more dangerous because unlike heart muscle, brain tissue, brain cells are way more sensitive to anoxia or lack of oxygen. And so the longer the brain has been anoxic, the more, and again, I'll leave the expertise here, but essentially the way I think of it, the softer the brain gets, and the more likely it is for bleeding complications to occur. And so at some point, the benefit starts to outweigh the risk, or the risk starts to outweigh the benefit. And now we've decided that point seems to be about 4 hours, 4.5 hours. So beyond that, if you can't get the TPA into the person in 4.5 hours, then you don't give it. Because the risk of them bleeding and, of course, producing a different type of stroke increases. Okay?
So, can I actually interrupt there?
Absolutely.
I have a question that came in, and that's actually really good timing for it. The question is, what treatments are available then for those who do not qualify for TPA?
Initially, it's basically symptomatic, because once that's happened, once that window has passed, we're basically treating the symptoms, meaning the stroke process goes on, much like an MI, and you can support it by treating the symptoms later on. But yeah, there isn't anything that we can do to reverse it at that point.
Thanks.
Good. So, going back to the case, thinking about this, did this particular patient meet the last seen normal state of health criteria? Why not?
You can't determine the time detail.
Exactly. Okay. So, next thing I just want to do is, so we now have a sort of a clear picture of who it is that we might want to bypass, right? 3 physical criteria, 1 time criteria. So what would be contraindications to stroke bypass? And I've just listed them here. And I really wanted, because these are the ones that you wouldn't necessarily bypass. These are the patients that we would take at this point in time to the closest hospital. And I just thought we would review them really quickly to make sure that everybody understood what they actually were and why these would be contraindications. So the unstable patient, what do we mean by an unstable patient? That's on the stroke card, but they don't really define what it is. So what do we mean by unstable?
We've got an irregular heart rhythm or something on the monitor that indicates arrhythmia, sensor. We were turned down in Stratford because of that.
Okay. How do you mean return down?
The doctor got very upset with us and said this patient is unstable. And he related it to the rhythm.
Okay. We may have a disagreement about that.
Well, good, because
Yeah.
we felt
We're going to talk about this arriving and getting
treated poorly.
treated poorly. Yeah, there were a couple of times that this will come up in the cases. I think we need to talk about this because this is I'm watching people's heads bobbing here about this. This is a common occurrence, and it happens both at the district stroke center and it happens at the local hospital. Okay, and I mean it's a paramedic issue that really needs to be addressed. Okay, and we intend to do that. And if we don't, remind us in the questions period. Okay, unstable. And why would unstable really isn't an arrhythmia? I would say unstable might be ventricular tachycardia.
I can't remember, it's like 6 years ago.
Yeah.
But I do remember getting really bad.
Yeah. Well, that's unfortunate. But as I say, ventricular tachycardia with hypotension. What we're basically talking about are people that might not do well with a long transport. Okay? So somebody who has airway troubles, somebody who has breathing troubles, somebody who's hypotensive. Okay, those are unstable patients. You guys deal with these. You know what I mean by that. Okay? So if somebody is hypotensive, we don't want to be putting them in an ambulance and transporting them for an hour. Right? Okay, or if they're in ventricular tachycardia, or they're having difficulty, or you're having difficulty with their airway or maintaining their airway, you don't want to be in the back of the ambulance with that person for 30 minutes. So these are people that they've got an immediate, unstable really means something which is immediate or urgently life-threatening things that you want to be, that should be treated before you can deal with these things. There's no point in bringing somebody to a district stroke center and having them die of an airway obstruction because it could have been relieved 20 minutes before. Right? Okay. So the second one is symptoms that resolve prior to paramedic arrival. Now, this is a difficult one because this is really what we're talking about, the TIA. Okay, so the person comes, they had the symptoms, however now they seem to be perfectly well. And this is sort of a slightly controversial area. And I think you'll see over the next couple of years that this criteria may actually get dropped. Okay? But for now, this person, if all of the symptoms have resolved, they're not going to get TPA. Okay? So this person has gone from sort of an emergent transport to a less urgent transport, and there's a whole series of things that we do for TIAs that have to be done within, again, a short period of time, but we're not talking minutes now, we're talking days. So, again, this is another contraindication, but you notice that the one magic word in that criteria is what? Prior. Okay? So if you arrive and the patient has stroke symptoms, okay, those people, and they're in the time limit, those people are to be transported. And we'll get back to the emergency department reception about this. So if you're, and I guess this is something which was an area where some people were confused from the survey that they sent out about the issue, what happens if I'm now, here I am on the other side of Walkerton, and I've decided to make it clear on the other side of Walkerton, and now, rather than, as I'm coming by, the symptoms have disappeared since we put the patient in the back of the ambulance. Do I take them to Walkerton, or do I go on to Lewell? And this was something that showed some confusion. According to the prompt card, yeah, go on. Okay? And I think this is an area that's a bit confused. There's some people that are a bit confused. Certainly the emergency departments are a bit confused as well.
I think the confusion mortified when we got there.
Absolutely.
Like, why did you bring this person here now that we're fine? And drove by to the office hospitals on the way there.
You can whip out your stroke prompt card and say, as it says. Okay? That's the sort of, it's as simple as, it's probably not the best answer to give.
I'm carrying mine now.
Good. That's one of the messages. Okay, so blood sugar less than 3, why is that important? Could be diabetic, okay, but would anybody else will try this side of the room first. Why is a blood sugar less than 3 something that we're concerned about? Bingo, exactly. Hypoglycemia can mimic stroke symptoms. Okay, so we want to make sure that we're not transporting somebody who's just hypoglycemic, and we all know that you would treat that person, right? Less than 3, decreased level of consciousness. Okay, so that's the other thing. Seizure at onset of symptoms are witnessed by the paramedics. Why is that important? It could be a bleed, but the other more important reason? Experience failing.
Would they not be unstable?
Potentially, but somebody who might have stopped seizuring and they're breathing okay and their airways open, they wouldn't necessarily be unstable. Anybody? This is one of the potential stroke mimics. Okay, so if we send all the people, because again, we sometimes see this, and they may very well have symptoms that have stroke-like symptoms, and so because this is a stroke mimic, that's included in the card. GCS less than 10. Anybody? Why would that be? Likely to be unstable, yes. And the other reason? Possibly, but I mean, usually if somebody's got a GCS of less than 10, they're not really moving around very much, and it's difficult to assess. But also, if somebody, because of the, as I was saying before, you've got 4 arteries that go to the brain, you're wiping out of those 4 arteries, usually one gets plugged up. It's really unusual, unless you've had a massive stroke, to have a GCS less than 10 with an acute stroke. Okay, they're more likely to be bleeds, right? Or as I say, the ones that are treatable are unlikely to be acute. If you're really sort of level of consciousness is really depressed, they're not likely going to get treated. Okay, so that's, and they're more likely to be unstable as well. Okay, 2 more. The person who's palliative or terminally ill, this generally isn't a treatment for people who are treated palliatively.
What about if they have a DNR? Is that a consideration as well?
That's a good question.
Well, just in that group.
Yeah, it depends why they have the DNR, I would say, because as we know, this is a whole huge topic in itself. What is a DNR and what does a DNR actually mean? You know, are we, and I think in those cases, and what we're talking about palliative or terminally ill are the people who are obviously, you know, in the process of dying or their death is imminently, or expected imminently. I think this is what we're talking about, as opposed to the person who says, if I had a heart attack, I wouldn't want to be resuscitated. Therefore, if I have a stroke, I might. See what I mean? It's a very furry area, absolutely, and some of these are very straightforward. You know, less than 3 clear. Palliative, what does that mean? Terminally ill, what's it mean? I think generally what they mean on the stroke card and what I think people's sort of feeling is that these are people that are basically they're expected to die soon, and so TPA really isn't a therapy that's likely to offer them anything. Okay, and likely they would have complications that would take them out of the treatment categories once they arrive in hospital. Okay, and the last, sorry, go ahead.
So the DNR, you're almost better to not even recognize it. Don't tell them you have a DNR, like if you're a patient. Otherwise, we not treat you. So then your care, you were not a golfing, person, and we're just talking about how. Yeah, no, but I know the DNR thing is an issue for you, but.
Yeah. Well, it depends on what the DNR is there for, and as I say, DNR as a whole, we could talk all afternoon about the implications of DNR and what it means.
I think it's not. As far as DNR is concerned, my approach is this. I think there are a lot of us, who always tracking whatever technical costs are checked, not necessarily things like that. So there may be a living will there that says make me a DNR, but the DNR is too broad for you to exclude anything. So even if the patient has a DNR, but as long as they are not going to die within the near future, they should be treated as though they are eligible.
And I would agree absolutely with that. So the last one is the duration of transport will exceed 2 hours. Why is that a contraindication? Okay. I mean, that's really not an issue here in Bruce County because you can get somewhere within 2 hours. So it's really, this one shouldn't be a big deal. Okay, so let's quickly go back to case 1. Here are the important history and physical information from case 1. Okay, the airway was patent, respiratory rate was 14, heart rate 64, blood pressure is fine, GCS is 10. Okay, blood sugar was okay, last seen normal, we don't know. Closest hospital 15 minutes away, stroke center is 40 minutes away. Where does this person go? Closest hospital. Right. And why?
Because
Okay. Everybody clear on that one? Good. How do you manage him? This guy.
O2, cardiac monitor, all the word. IV.
Airway, IV, the usual stuff. Okay, good. So, if this patient hadn't met the criteria for last seen in the usual state of health, and you could have gotten there, transport could have potentially been less than 2 hours because we're in Bruce County. Did he have any other contraindications?
GCS is 10, but it says here less than 10.
Less than 10, right. Okay, so technically, yes, he could have been transported. Okay, if the last seen time had been within the range, we would have transported this. Okay. Okay. So what do you do now? You take him to the closest hospital. So I'll pass case 2 on to Richard. Okay, next cases will be shorter.
All right. Now that we know Richard Chan, I work as a stroke neurologist at the London Health Sciences Centre University Hospital, and my interest is that acute stroke. Before I start with this case, just to tell you a little story, actually TPA has been around for a long time, and we use it for heart attacks. And when TPA became apparent that it can help stroke patients, there was a little bit of development there. We talk about the chain of treatment starting from home, go to the hospital, hyperacute care, then acute care, then rehab care, then outpatients rehab, and finally reintegration into society. There's this whole chain here. Now, if you look at this whole chain, when is the first point of contact with the medical service? You are. you are the first person who is going to contact this patient and say, my God, this patient has a stroke. And therefore, when TPA became available, when they wanted to do a trial, they need to have a very strong support from the paramedical services. So right in Cincinnati, they took 1 year to develop a lot of the things that we're talking today. For example, the Comcard, they actually have a very different version of it, but it was actually the EMS that made the trial possible. If none of the paramedics wants to do what we are talking about today, we would have never proven that TPA would benefit the patient. So that's how important you are in terms of stroke care. So with that, case number 2. So you are called to a residence, no idea why they called, but on arrival you were met by a woman whose name is the patient's daughter. She says that she stopped by on the way from home to work to check on her father, the patient, who lives alone. She spoke to him by phone a few minutes before she left for work, and he said he was not feeling well. His speech was, however, clear at that time. Then she says he's a healthy man, no medical problems, maybe blood pressure a little high. So, but when she arrived, 30 minutes after the telephone conversation, saw him sitting on the chair. He was awake but unable to speak clearly, something like me now. On call last night, so I'm having a little bit of slur speech. Could not move his left arm, or he could not get out of the chair. So you reassess, you reassured the daughter and proceeded to assess the patient. So, does this patient have symptoms that might indicate a reason for you to redirect the patient to a stroke center? Yes, no? Okay, so let's go through, we talk about FAST at AST. So, let's go back first. So, there was nothing about face that we could see. Anything else? FA, arm? Okay, there was arm weakness. FA, as speech. Speech was slurred. So he still clearly has symptoms. Let's talk about the last one, time. Does he fit the criteria?
It says last seen.
Last seen normal, or we call it last seen well. So who was he last seen well in this story?
It never says.
Say again?
It never says.
Never said.
Spoke on the phone.
Spoke on the phone. And he said he was not feeling well.
But his speech was clear.
But his speech was clear.
But she didn't see it.
Correct. So there's a little bit of, obviously you have to make this basic way, and also that you can discuss about it. All right, if the patient says, when the daughter is talking to the patient and he was clear, his speech was clear, and he said, I'm doing well, no, he's going to come see me, and then with the daughter trying to see him and found him in that state, that is clear. The time of onset was, after they had spoken on the phone. So the last thing, well, in that case would be 30 minutes prior to the daughter seeing him. But in this case, he said he was not feeling well. We don't know what that means. All right? Maybe he's having some tingling in his left arm, or maybe he's having some weakness in his left leg, so he's not feeling well. And unfortunately, no one kind of probe at that point. But if you were to be there, what would you try to, what kind of information are you going to try to get out from the daughter?
Yeah.
Other than that, in terms of time of onset, what kind of questions would you ask to try to determine if the patient was well or unwell at that phone conversation?
When was the last time you've seen them?
All right, so that will be a good question. So maybe the daughter saw the father last night, and that might put the patient completely out. Or if you are trying to see if the patient is eligible, just find out, okay, when you talk to the patient, did he mention anything about his strength, his sensation, anything that at all that would help you determine if he's well or not. All right. In this case, we are going to hinge on the speech. Since speech was a part of the symptom complex, we can certainly assume that when we talk about he's not feeling well, he's talking about something else. He doesn't have stroke symptoms. In that sense, he would be eligible because we don't want, you to eliminate too many patients at this stage. All right. And I always talk when I used to give talks to medics, paramedics as well. I always remind them, you are not required to make the diagnosis of stroke. That is not your job. All right? But you need to identify the symptoms that might suggest that the patient has had a stroke. As to whether the patient have a stroke or not, that's not your job. Leave it to the physicians down the road to do that. Your job is to see if the patient has that symptoms. If he does, and if he qualifies, we'll give the benefit of the doubt to the patient. All right. So, assuming that the patient, when he say I'm not feeling well or I have a flu and I'm just coughing, so if that's what he meant by I'm not feeling well, what would you do? Do you bring him to the local hospital? Do you bring him to the stroke center? Because he has the symptoms and he fits the time criteria. Right. We already talked about this. Does the patient meet the last feeling well and criteria? So just to review it, really depends on what the patient meant by not feeling well. If the patient's got to get a clear message that he's having symptoms, that is consistent with a stroke, then that probably will put him out. Unless the patient told the daughter, "Oh, I woke up this morning, I was fine, I had my breakfast, and at 8:05 my left arm became Continuum," right? But that would never happen in real life. All right. So important history. So at this point, when you examine the patient, his airway is patent, he's breathing 0.4 breaths per minute. Blood pressure was 184/100, pulse rate was 96, GCS is 12, blood sugar was 5. And in this case, it's making it easy for you. Last seen well, or normal, 53 minutes from symptoms onset to your arrival. Okay? Just to go through this very quickly, and I just want to emphasize GCS. GCS is not a very good tool to assess stroke patient because if you look at the criteria it uses, it wants to get the maximum score possible. All right, so for example, movements. So as long as the patient is able to move one arm, all right, even if the other arm is totally paralyzed, you give points just because of the good arm. So in theory, patients, who have just weakness on one side, this GCS could be 15. All right. So GCS in this case is really used to reflect in a certain way the severity of stroke. If the patient has depressed consciousness, and that's where you lose point from GCS, and that might potentially take the patient off the criteria. Okay. Now, so this is the physical examination findings. How are you going to manage this patient? Well, you already made up your mind. You're going to take the patient to the stroke center. So, what are the steps that you're going to take to get the patient there? So, at his house, what will you do to the patient?
We're going to know. Let him know what we're going to do.
Right. Describe the plan. Report the plan.
But dispatch, no.
Okay. Yeah, actually, I don't know. But so, if your procedure
But I
says,
mean, regular care.
okay, which would include
Oxygen.
oxygen. Say again?
Vitals,
Vital.
probably.
Okay.
ECG.
ECG, IV. Okay, let's talk about IV. Any special requirement for IV?
AC, 20.
20. No. 20. 18. Right. So you want a 20 cubicle.
It's like when you're on the spot.
Was that right?
No, now, our radiology department only requires
Oh, okay.
Right, so that's why it's.
My fault, sorry. Our radiologists are what is something wrong. And the reason, actually one question is when you put in anti-cables on which side? The good side or the bad side? The good side. Yeah, and that's probably the best place to put it because in case they want to access the arm, you don't have the IV there blocking it. And the reason for London we wanted 18 is so that we can give contrast if we want to do a contrast, a CT angiogram, things like that. But if you don't, then I guess 20 will be enough. So my fault for that. Okay, so you could do whatever you could. You load the patient out the ambulance and start driving. Prior to arrival at the stroke center, anything else that you would do? Okay, so you for the hospital. Okay, and that's I think is a very good point. Pre-notification. In Owen Sound, it's easy because basically it's the emergency room physicians who basically are responsible for the care of stroke, a patient with acute stroke. Whereas in London, it's actually a neurologist. So like me, I said I was on call last night, so I'm happily watching television. And if someone paged me, that's the time when I'll start running to the hospital. From my hospital to the emergency room is exactly 16 minutes, sometimes plus minus 30 seconds. And unless you tell me beforehand, I will never be able to get to the hospital on time to meet the patient. So in certain centers, pre-notification is very important because you get the physicians ready. In fact, in London, the minute we know that a stroke patient is coming, the CT scan will vacate at the table right away. They will wait for the patient to come. So 2 weeks ago, I was on service. We got a call that a patient is coming in 25 minutes time. So at that point, we vacated the table, except the patient was delayed. And all of us knew in the SARS group, we were just reacting and all, talking and all, and we waited for about 30 minutes. All the time, the CT scan was still waiting for the patient. So we wasted 30 minutes of the scanning time. So just remember, to do notify us, keep us updated so that we don't let resources go to waste. Any questions? No? Okay. That's good.
Yeah, the radiologist will tell us nervous, I guess. Anyway, case 3, I'll just hit the highlights here. You can mostly read it. 38-year-old woman, previously well, suddenly collapsed, unable to move her left side. Okay, husband recognizes this as possible stroke, calls 911. Okay, so when you arrive, woman's conscious, lying on the floor, left side of facial droop, unable to move her left arm or leg. Speech is slurred but partially understandable. We just come back from Europe. She felt funny at the time, bit of dizziness. Okay. So, in the ambulance, you decide that this person, we'll talk about that in a minute, but she can't lift her arm, but she starts to improve once you're loading her. Okay? So, with this particular person, does this person have symptoms that might indicate a reason to redirect?
Yes.
Yeah. Okay, why? Yeah. Exactly, and you're certainly within the time frame. Okay? Does the person meet the last normal? Sure. Straightforward. So other important information, airway, basically vital signs, and the reason for the top 3 are what? We're establishing whether she's stable or not. Okay, and this woman clearly stable. She's got a GCS that meets really no contraindications here at all. So blood sugar is 4. Last seen normal was 28 minutes ago. Okay. So the question then is, she's starting to improve. She's able to make a fist now where she couldn't on your arrival. You're just loading her in the ambulance. You're not actually underway yet. Does she still meet the criteria?
Yes.
Anybody have any questions about that one? Good. Go on to
Okay, this is almost like something that happened to me years and years ago when I was a resident in the States. So you call to be at the go to a grocery store because someone, apparently fainted and collapsed in the store. When you arrive, the witness reports that we saw the patient in the produce section when she suddenly just collapsed. The witness went over to help her and she complained of a sudden onset severe headache that was getting worse. Quickly assessed the patient and he found that the patient's level of consciousness is decreasing rapidly over the last 10 minutes. Now, before I go to the next slide, what are your concerns at this point? What do you think is wrong with this patient? Cerebral hemorrhage. If I get that history, yeah, I would too. In my case, I didn't have any headache, thank God, so I didn't have that. But it's very embarrassing fainting in the grocery store. When you walk up, I can go to the store for the next 2 months. So when examining the patient, she was moaning, she extended her left arm and left leg, but no movement at all on the right side. Her pupil, the right side was reactive, but the left pupil was dilated. What are your concerns at this point? No change. Cerebral hemorrhage is probably getting worse. Right? Say again?
So let's get going quickly.
Correct. Now, does this patient have symptoms that might indicate a reason to redirect or travel directly to a stroke center? Yes? No?
She's decreasing, so you would go to focus hospital.
So we're talking about stability. She's unstable. So even though she has symptoms to suggest a stroke, a cerebral hemorrhage is a stroke. Even though we don't treat them with TPA, but they will still benefit from a certain form of intervention. So you will still want to bring them to the closest, to the stroke center if the patient is stable. But in this case, the patient is not. Right? The pupil is already dilating, the level of consciousness is dropping, something is growing inside the skull and it's causing a lot of pressure and it's pressing on the brain. Now, having said that, because of stability, you want to bring her to the nearest hospital. But at the same time, sometimes you need to think about hospital resources. You go to the local hospital, or they have, emergency room physicians and insurers. And basically, they saw this patient, they can't do anything. No one's going to crack the skull and start draining the blood clot. They may not even have a CT scan. So is it better in that case then to send them to a stroke center? So what's your view?
But if they're unstable, we have to follow our protocol.
Okay, so the protocol says that. And pretty much, I've been asked this many times. So let's say, local hospital, 20 minutes. Stroke center is in the other direction, 30 minutes. Which do you pick? Or they're 25 minutes either way.
Stroke center.
Yeah. So sometimes, you can think about the hospital resource. If the patient is not unstable, and if there's not much of a difference, it's something that you could think about. I'm not asking you to break a protocol. It's just something that you need to think about. If the local hospital is really near 5 minutes and the stroke center is 30 minutes, without question, you go to the local hospital because they can stabilize the patient and then the physicians can make arrangements to transfer the patient to another center. Right? So that would probably be the usual scenario.
This has come up for myself, and once again, you bring a patient into our local ER or the area, they're going to yell at you till a strip off you for no smile. Because you haven't, why did you bring this patient here? This patient here, you have to stroke him. Why didn't you bypass and go to the stroke hospital? And so you're wasting time for the patient, and it's embarrassing. Family members or whatever. And so how do you justify that? Even though you show them that the trusted little card maybe up.
Right away, it's not stable. Is the patient stable?
Yeah.
If you assess the patient to be unstable, then you did exactly the correct thing. So, you know,
What's another option?
Call your supervisor. Or this hostile.
That's why I'm here. That's why I got invited. Yeah, you can always patch. If you're in a situation like this, I mean, the way this case was presented, technically speaking, with the exception of her decreasing level of consciousness sort of rapidly, technically speaking, she's still stable hemodynamically. Airway, breathing, circulation, right? She's unstable from a level of consciousness point of view, and the pupil going out, which, and again, she probably wouldn't survive given that story. She's not likely going to survive a long journey somewhere else. And yes, you might get yelled at if you brought that person in, because by the time they arrived, it would be really, I suspect it would be really clear that that's what's going on. And let's face it, some of the smaller hospitals would have a lot of difficulty dealing with a patient like that. They should be able to, but it depends entirely on who's working and what's going on. And so in that situation where you're not really sure, or it's a little unclear, or maybe it might be only 10 minutes, call for advice. That's what the base hospital physician's there for. Okay?
okay, thank you. So, does this patient meet the last Lewell criteria? Yeah, you know, when you pay, you know, grocery store, everybody knows what Alright, so important history, airway was patent, respiratory rate was 6, heart rate was 68, regular blood pressure was elevated, 184 over 100, GCS 5, and that's probably from the loss of consciousness, decreased level of consciousness. Blood sugar 5.5, lasting well 38 minutes, closest hospital 10 minutes, stroke center 25 minutes. Now, this is your examination, so based on this, what is your determination? Why? GCS is low. So this is less than 10. So without a doubt, at this point, you go to the closest hospital and they can stabilize the patient and then decide what to do after that. So management of this patient, a little different from the previous one. So what would you do at the scene, and what would you do in the ambulance?
You'd be bagging her. You'd be bagging her.
Correct. Right. So basically, you need to make sure that the patient respiratory support is there. You want to monitor the heart, the cardiac rhythm closely, because she may go anytime. I mean, the heart may go anytime. Okay. So this one you're going to need more monitoring, and pretty much be prepared to support her in terms of respiratory function. All right. I think that's the last section we need.
Okay, thank you. Okay, last case, 56-year-old male who's experienced a sudden onset of slurring of the speech. I met the patient's wife. She noticed that this just happened. She reports that he's been previously well, hypertension, high cholesterol. We find the patient sitting there. So there's not a lot of other information about that. Okay? So, based on what's on there, would this person meet the physical criteria for getting to a stroke, district stroke center, or presumed stroke?
So far, yes.
So far, yes. Okay, why?
For speech.
Okay, right.
Sudden.
Exactly. So, other important information that wasn't included, you then go ahead and you do your exam, and this is what you got. Okay, airway's okay, respiratory rate's normal, heart rate's maybe a little up, but blood pressure's okay, GCS is 15, blood sugar's okay, last seen normal, we're assuming is 20 minutes. But now you're kind of outside of Bruce County, but we'll just, well, no, we can do something here. Suppose you were
told them worry and the on-sound site's down, so you have to go to Goddard.
Yeah.
It's a telestroke. So.
There you go. Okay, the CT scanner and one sound, you were notified at the start of the shift. He's down.
That was a 3-hour trip, right? From full morning to college?
That's what we're saying. Yeah.
Yeah, that's 2.5.
Yeah, it's 2.5 hours drive.
You're still good.
So would this person be transported?
Yes.
So it's saying transport time 2 hours.
Yeah.
So what's it? Yeah, I thought, now I'm going to say it, then maybe I'm wrong. But I thought it was 3.5 total from time to onset.
That's what I said. That would be 3.5 hours.
So if it was
So
45
what is the 3.5 hours?
But it's allowing from onset
to the door of the facility.
Is it going to be the drive?
I thought that's
No,
four.
it's 4.5.
Yeah.
4.5 is the time from onset
So
to
onset,
treatment.
yeah, onset to door I thought was 3.5.
Yeah.
Yes.
So would this person fall, would you bypass on sound and everything
That
else?
slide earlier said transport time of 2 hours.
So I'd call it hospital.
And that would be an
I just covered
absolutely,
my butt.
no, that would be an absolutely reasonable thing to do. The reason that they're using this sort of 3.5 hours is that it takes, in most places, it takes an hour to do the assessment, get the CT, and the important bit is the lab work. Now, did you?
Sometimes you pray and say, okay, don't play a small one, we just give.
Yes, okay. This happens, and it happens in own sound as well, where we just say, if we know that somebody's not on a blood thinner, warfarin, the chances of them having an INR greater than, that would take them out of the range are pretty small. So we might do the same thing. But again, it's a bit of a roll of the dice, and it depends on who the physician is that makes up the mind. So the point here is that you want to make sure that they're in the window. 3.5 hours is the window from onset to delivery, if you like, that might put them still within the treatment window. Okay?
Why is it 2 hour thing in here?
I think that was in the original stroke card was made when they had when we were only giving it within 3 hours. Okay.
Yeah, there was, all right, this was 3 hours, and so that would.
That's right.
2 hours.
So they were. That was the old transport time was 2 hours, because then you could have an hour in hospital and still make it. Okay, well, really technically not. But
So now not only 2 hours, it's only 3 hours.
I think in your setting, there's virtually no days that you would ever be more than 2 hours. Right. So it's really a moot point. Okay. So we can, this is arguing about heads of the pin and all that stuff. Anyway, so how would you manage this patient? Maybe we might have to go backwards here. Let's just, yeah, I can. Okay, so this is a patient. So how would you manage this particular patient?
Monitor, oxygen,
Yeah.
ECG,
Your usual stuff and the transport. Lots of music. Okay. So at the end of that, there were 2 bits of things that I would like to address, and one of them was the issue about the family and what do you do about the family, because a lot of the stroke patients aren't able to provide the information that's required for their ongoing care. Okay, if somebody's got slurred speech or no speech, how do you ask them questions? Or somebody who's confused, how do you ask them questions about the important medical information, including time last sleep? So this raises the issue of how do you deal with the family, because you're very important to decide this problem, because if the family has decided that after you leave, they're en route to the district stroke center, I mean, they might have gone to pick up Aunt Nellie first and then deliver the dog somewhere else and then come, and so it may very well take more than 2 hours to get there. It's possible it happens. So how do you deal with that? Because you're vital.
I try to get the friends involved to
Yep.
to become a training partner.
Yeah.
They usually do is leave.
Yeah.
To come with us,
the other piece that I would suggest would be try and get a call number for them, cell phone number, some way to contact them, because that's really important. So if you can kind of stick that in the back of your head about trying to make sure that we can get a family contact. Because as the medical records have computerized, it's great now. I mean, I can access information from, assuming the person has a medical record anywhere in Greenwich counties from any of the hospitals in Old Sound, I can access that information. Okay, but and that's very helpful because a lot of the past history and things I can get from that, but I can't get some of the details, and you might not have some of the details.
I just have sort of a question for Ray. We shouldn't really taking family with us though.
It's one of those things you're going code for. It's not as safe for them. If you think it benefits the patient, you got to look at that situation. And if they could be up front and seatbelt it in, it's better than you don't necessarily want them in the back, but you almost have to think of it like an older patient bringing along to the thing too.
So belted in the front is where
That'd be the safest place, and then you know that you're going to get them there if they're able to come in.
I completely say probably, especially when you're talking about elderly family members who have difficulties getting to the hospital, without transporting them in the ambulance, perhaps just ask them to stay home by the phone. We will call you, but make sure you get the numbers for us.
Yeah. The number, the way to contact them is really important. Or if they're going to the neighbors, you can phone and they're not there. It doesn't help. But try and find out how you can make the contact. And that's really, really helpful. So the other issue I just wanted to bring up before we open it up for questions is, I mean, it's been raised several times, and the heads all are going like this about the treatment that you receive in the emergency departments when you go either to a hospital that is in a district health center or district stroke centers, or not at the district stroke center. So the issue here becomes the bypass cards are pretty straightforward, and I think after today everybody should have a pretty good idea of what the expectation is as far as what you're supposed to be doing with these people. Now, we're not able to control always the reaction that you get, and if you maybe provide a little bit of perspective from the hospital perspective, stroke patients are they're sometimes difficult. Certainly, if you haven't had much personal experience yourself treating stroke patients, they're challenging. And a lot of times, again, the diagnostic procedures, virtually all of these people will get a CT scan at some point. And so the argument then, from the hospital, from a local hospital's point of view, is, well, what are you bringing them here for? They need a CT anyway, blah, 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 blah. You might as well just take them on. Or they don't have the resources themselves to deal with some of these issues. And certainly, I think where this is ultimately going, and I think what Joan was sort of saying, was that ultimately stroke care will probably be regionalized. It's not there yet. And some people are saying, well, this is the way it should be. This is best practice. And so they're saying, well, we're going to take them there, but the current district stroke center that you deal with, the district stroke centers that you deal with, aren't prepared at this point to take all comers. I mean, they're willing to look at the people who might benefit from TPA, which is what the bypass is about, but people who are really outside the criteria, the district, or at least the hospital in Lewell Sound, isn't prepared to take everybody all the time at this point. We may come to that. I mean, that day may come, and that would be great. But at this point, not. But from a local hospital point of view, there are physicians who have treated people with stroke for years and years and years. And they don't recognize necessarily that all of these patients should be transferred. And that's another issue that you're going to run into. So there's a whole bunch of things that, we basically have to navigate. And unfortunately, you're put in the middle of this sometimes because you're told this is the expectation with cards. These are the is to hold up the card and say, this is what we're supposed to do. And if you really get hassled, you've got a supervisor. Sad to say, occasionally it does happen at my own hospital that people will get hassled for bringing patients who are clearly not strokes or whatever, but it didn't. The other thing that you have to remember in medicine is that you're seeing somebody here, an hour later they may be quite different. And that's the nature of looking after humans, is that they change over time. They can sometimes get better, they can sometimes get worse, sometimes it's not. And so you see the person here, it's completely different than when you saw them and you made the decision. And unfortunately, not everyone recognizes that. And especially if they're busy and stressed themselves and all these things. And, sometimes people behave badly. One of the functions that the base hospital is there to help provide is, or one of the things that we do are to sometimes act as the one who will occasionally intervene. So the base hospital physician that you're patching to, you can always patch for advice. If there's a big blow up and there's a particular incident that happens at a hospital where it's completely inappropriate and supervisors may not be able to deal with it, it may just require a cooling off, and then it gets dealt with. And as the local medical director, I have had to go occasionally and have discussions with the physicians to say, what you're doing is unreasonable. What you're behaving is badly, and if you want this kind of thing, then this is, so this is what the base hospital also is there to do. And we occasionally do these interventions where we actually go and talk to the physicians, talk about why they're feeling the way they are, and help them understand the issues. This is in any system. We've got the people. Everyone has their own ways of doing things, and they have their own understandings and their own perspectives. And so each one has their own, and it depends on what they're doing. And people have to realize that in multiple agencies, these things become really kind of complex. And it's incredibly unfair that you're put in the middle of it. And I acknowledge that. But sometimes you have to deal with it at the time, and then you'll try and make the system better.
Why is there such a difference with, like, we do 75 passes in Free County, and they go to Lewell during private one, and yet if you do a stroke bypass, it's a very different story. Is it because it's so clear cut with STEM?
Oh, there's lots of
Don't even go there.
It's a very complicated answer.
It was just so unusual. It was an experience actually to go down there and to even see it on that level. When you usually have your back up and prepared for a backlash of some sort.
It depends who's driving the process.
Okay.
Yeah. I mean, I'll be perfectly honest. Yeah, absolutely. There's politics involved in this, and it really just depends on positioning, and of course everybody is different. Anyway, I just want to open it up for some questions. Either Richard or stuff.
How much education is passed on to the hospitals as far as our protocol on this is concerned? Like, that seems to be the general gist of all of it is we get there and they're not quite sure of our protocol. Like, we're sure of it, but they're the ones asking why is this patient coming here?
The answer to that question is that it's spotty, and it depends on which hospital. And like so many things, you can go and you think everybody's on board with something, and then people come, people go, they bring their own ideas, and you have to keep doing this over and over and over again. This is where Lindsay and Gina can probably give these presentations over and over and over and over again, just simply because people change, and you'll have somebody who will have a completely different idea. physicians are self-employed, essentially. They're not employees of the hospital, and so where nurses, sort of the hospital can say, this is what you do, and hesitate to say this is what you think, but this is at least how you're responding in this situation. And they can enforce it if they don't. Physicians, because they're not employees of a hospital or an institution, much more difficult to get everybody to agree. And as you know, physicians generally have strong personalities, and I mean, you can see this within the base hospital. I mean, we have finally put together a mechanism where we work out our differences, but of the 4 medical directors, I mean, we each have very strong opinions on virtually everything, and it's a matter of doing it with consensus. When you take all the physicians in this county, we've got a lot of physicians that you've got to get on the same page. And Richard spends far more of his time doing this than I do, but it's very difficult. But I think this is a process. It's a work in progress, and it's sort of moving along, and it's moving in a certain direction. And this is part of why we're here today, is to help move it along in that direction, so that the more people are that we can get on the same page, the better it is. Any other questions?
On a plus side, though, I had one of the doctors who asked me what our protocol was, if I had something in writing, and with me, and he was very gracious to they actually protocol it. So it was on the plus side.
Can I just make a note? And based on the Survey Monkey results, we were seeing a lot of responses saying that the crop cards, they're tattered, they're torn. So we've actually printed 100 for blues and 100 for grays. We heard that was an issue. So you should all have new copies.
Still don't put the washing machine there.
If I could, I'd just like to address one of the questions that you asked. What happens to patients who don't meet the 12.5-hour window? Actually, it's much broader than that. So obviously, if you bring a patient to the hospital and they have stroke symptoms, the next thing after examination, they will get a CT scan. And from that, we know if the patient had an ischemic stroke, where it's due to blockage of blood vessels, or hemorrhage, where it is due to rupture of blood vessels. And all of you know TPA that can be administered within if it can be administered within 4.5 hours of symptoms onset, it improves the outcome of the patient. 3 months. When you assess a patient 3 months down the line. Doesn't mean that we leave all those who are more than 4.5 hours, kind of out there by themselves. There are other treatment procedure, but they are considered investigational, and they are only available in selected centers. So as a result, this is not included in the prompt card. All these other interventions you may have heard, we can do intra-arterial thrombolysis where we give TPA, but not through the IV. So we actually get the radiologist, do an angiogram, and we direct the catheter all the way to the blood vessels that's blocked and inject the TPA there. For that, we have a window of up to 6 hours. Then you must have heard from the news there are all kinds of devices where we can do either yank up the clot, suck up the clot, or anything just to get the clot out. So you have devices like Mercy. Sapopapa is the one that retrieve. So these are all special catheter that you need the radiologist to do an angiogram, to direct the catheter up to the blood vessels, look for the thrombus, the blood clot, and then you literally just remove it. So that's what we call thrombectomy, removal of thrombus. For that, depending on the device, we can do that for up to 12 hours. Now, beyond 12 hours, we don't have anything even for investigational. But the important thing about all these investigational procedure, number one, although we, at least they claim that they are safe, but they have not been shown to be effective yet. They have not done a trial to compare patients with and without those procedures. And number two, they are highly specialized, so you cannot expect all stroke centers to have expertise who can do this. What about hemorrhagic strokes? Hemorrhagic strokes, obviously, we're not going to give them TPA. So, but you know, a lot of times when if the patient have a large hematoma or blood clot in the brain that's causing a lot of pressure problems, that they are likely going to die soon, the surgeons can go in and remove the blood clot. That would improve survival. Without a doubt, the patient will survive. The only question is, will the patient improve functionally? So basically, just, you know, we don't want to turn someone, you know, who's going to die from a blood clot into a vegetable. You know, that's not the ideal treatment plan. And according to some studies, you know, early intervention to remove all these pressure-causing blood clots does improve survival as well as function. But, you know, the data is not very convincing at this point, so most surgeons actually don't do evacuation routinely. But certainly, you know, in selected cases, they will intervene if needed. So that's the answer to the questions. And actually, I have one question for you. One of my colleagues, you know, has very bad luck whenever he's on call. You know, we call him the intoxicated stroke. You know, many times when he's on call, you know, patient will come to the ER on stroke protocol. The patient has slurred speech and was uncoordinated and is drunk. Would you have brought, you know, take this patient to the ER? You know, you so they call you to the bar where they say the patient has slurring of speech and uncoordination. Would you, you know, if you go by the cards, you know, he's got face, he's got speech, time is on set. Would you bring him to the hospital? How many of you would use the stroke bypass and take him to the ER? None. How many would not? Right. So unfortunately, you know, my colleague, he collected a series of 8 patients in 1 year. I had 2 personally, you know. So sometimes, other than following the card, you may you may need to use a little bit of common sense too. You know, so patients who are drunk, they are going to have slurred speech, they're going to be uncoordinated. On the other hand, if you go to the bar, you know, other than slurred speech and you know, uncoordinatedly, if he's not moving his right arm or right leg, you know, that's different. Alcohol doesn't do that. All right, so by all means, bring the patient in, but otherwise, I would say, you know, sometimes a little common sense can save you a lot of hassle, so no one will scream at you. That's all I have to say. Questions again?
Are children treated any different with stroke symptoms with bypass?
No. The answer is no. If we don't see them that often, but we do see them. And I don't think that Richard Donat or stroke, right. But I don't believe there's any difference.
There is no studies to look at the safety and effectiveness of PPA in children, but a lot of big centers do thrombolize young children with stroke. Remember, if children have strokes, they tend to have strokes due to other causes. In the adult, we talk about narrowing of blood vessels from atherosclerosis. We talk about hypertension, things like that. Kids are not going to have that. So usually the causes of strokes are very varied. So depending on the cause, treatment may or may not be administered. But if there is an obvious blood clot blocking the blood vessels, most would still go ahead and treat them. We have a children's hospital in London, so I don't encounter them often. The youngest that I've treated is 10 years old, so he's a boy. In Toronto, Children's Hospital, they have collected a series of, I think now should be about 400 patients across the country. At least so far, based on their analysis, the effectiveness at least should be comparable to adults. So therefore, if we have children who have typical stroke symptoms, certainly I would consider, putting him into the stroke bypass protocol as well.
And just to add to that, Richard, sorry, was that the Canadian Best Practice Guidelines, the EMS ones that Joel presented earlier, they've made references here to pediatric. So, but as you said, it's not been tested in that population, and the inclusion criteria, the more TPA, that you're 18 years, right, or older. But I'm sure there's situations where you might have a 17-year-old that has the same body size as an adult, and if everything fits, they get to be a
Those would be off-label use.
Yeah, I think in your setting, it would be extremely unlikely that anybody would end up actually getting TPA as a pediatric case. But I mean, if it's clearly stroke symptoms, I can virtually guarantee that those children would end up either in Owen Sound or London on referral. And so they're going to need to see a pediatrician anyway. And given that that's the only options here for you, I would think that would certainly be an appropriate case to bypass. And again, if you have any questions or you're not sure, call the Mace Hospital physician.
I just have one comment to make. Sorry, I think in the survey there were some questions about garbage and their CTCM being down. So Gina did some work and had some conversation with that. Sorry,
Thank you.
Gina had some conversation with the manager at Garbage, I believe. And some of the problems that we were having were not actually related to the CT scan. It was related to the staff that was available in the ICU post-TPA. So when it looked like there was the CT was down a lot, they were diverting patients because they didn't have staff for post-TPA care. But they have rectified that problem. There is work with the critical care network that does allow people to close beds or restrict care. So that shouldn't be happening as frequently as it sounded like it was.
So we're a little bit over time, and it's a beautiful weather out. So we're going to have a round to half if there's no further questions. Again, I'd like to thank Dr. Evie and Dr. Chan and Joan for presenting today, as well as the rest of the planning committee, and Stephanie and Michelle for setting up the actual webinar, and Ray for actually hosting this today. And if you can, and last but not least, the evaluations, we really do take your feedback seriously and really look at incorporating it in future events. So we really appreciate you filling out the feedback form that's in the package, as well as we're sending out a survey link as well. So thank you.